We're going to start with our lunchtime panel here, and I'm really excited to have some terrific organizations represented to talk about how their organization is working with this issue. And I'm extremely excited to introduce our moderator, Dr. Joseph Greer, who is a clinical psychologist and researcher at the Massachusetts General Hospital Cancer Center. And he's been a big part of our event for the past 3 years, and we're delighted to have him moderate this panel today.
Thank you.
Joe, take it away.
Appreciate that. Good afternoon, everyone. All right. Who's going to reject an applause? Thank you so much. We're really excited to have our panel this afternoon. We're hoping to have this be a bit more conversational, and we've invited some guests who represent various national professional societies, community organizations and alliances, hospital organizations, who can speak to this issue of equity in cancer care from a place of mission. You know, how do we come together in a broader community to make change? And so allow me to introduce my colleagues here who will be presenting briefly. Each one will speak for about 5 minutes about their work and the agencies they represent. And then we really do want to open this up for conversation and get your insights, brainstorm together, and think through how we bring together our shared personal, professional expertise to make change. So first I'd like to introduce Terry Mulvey. Dr. Mulvey is the Director of Quality, Safety, and Value for the MGH Cancer Center and Director of Breast Oncology at the MGH North Shore Cancer Center. She's also served on the Board of Directors and Quality Committee for the American Society of Clinical Oncology. Next to Dr. Mulvey is Dr. Michael Sharp. He is Professor of Psychological Medicine at the University of Oxford and President-elect of the Academy of Consultation-Liaison Psychiatry. Next to Dr. Sharp is Vicki Kennedy, Executive Director of Oncology Strategy and Patient Engagement for Solaria Communications Global and current President of the American Psychosocial Oncology Society. And sitting next to Vicki is Dr. Tara Schattmeyer, Assistant Professor of Medicine at University of Louisville School of Medicine and in the immediate past President of the Association of Oncology Social Work. And coming up next is Ruth Switzer, is the Director of Membership for the National Alliance of Mental Illness in Massachusetts. So thank you all so much for joining us today. Yes, absolutely. So before I turn it over to my colleagues, I have to say I was really struck by the testimonies earlier today and the varied perspectives of how we think about this work and what does it look like when it goes well, when we think about integration of supportive care, good mental health care, good navigation, good social work, ensuring that patients, at-risk patients, the most vulnerable patients, including those with severe mental illness, receive the cancer care that they should, the highest quality cancer care. But just 5 minutes ago, I was having a conversation with one of my table mates who is the only clinical social worker in her community regional cancer center. And I think that is a story that happens all too frequently. And the question comes to us, how do we implement such change in innovative ways when we know that the variability of resources is tremendous? And I'm hoping, let me say in the words of Dr. Inga Lennes, I'm curious to ask my colleagues about their thoughts on this. You know, from their perspectives, from the national societies that they help lead, how do we move forward given such tremendous variability in resources and access to care? So I'm going to turn it over and allow each of my colleagues to share for a few minutes. So thank you.
Sure. Thank you. Thank you. Again, I'm Terry Mulvey. I'm a medical oncologist. And I'm here today to represent the American Society of Clinical Oncology, which is the largest membership organization for those individuals who are treating cancer. That includes medical oncologists, surgical oncologists, radiation oncologists, nurse practitioners, and increasingly oncology social workers and other affiliated folks, rehab and such in oncology. As Joe said, I don't work for ASCO, I work for MGH, but I'm a perennial volunteer and have served on the board, and currently I'm the chair-elect of the Quality Committee. A year ago, my colleague Rich Shilsky was in this position, and I reached out to him when I was asked to participate in this conference. And a lot has happened behind the scenes because of that invitation. And right now, ASCO has convened a task force regarding rural health. And rural health means a lot of things to a lot of people, but what it often means is that there are not a lot of resources available geographically and numbers-wise for patients in rural places in the United States. And we know that rural health, that the cancer rates are higher in rural communities, and we also know that the death rates are higher. We also know that the risk of substance abuse is much higher in those places. So this, to Dr. Shilsky's mind, dovetailed with what he heard at this meeting. We had a very long conversation with him and with the CEO of ASCO over the past week about is mental health something that is only to be thought of in the rural health setting, and the answer was a uniform no. And although it has never been something that has been directly addressed by ASCO, it is something that will be directly addressed through a board-appointed task force, and the invitations for that board-appointed task force will be going out in the next several weeks, and Dr. Irwin will be asked to be a co-chair of that task force. The purpose really is to develop a white paper around identifying the drivers that create the gaps for patients with serious mental illness, either who have a pre-existing diagnosis or a diagnosis that may never have been formally applied to that individual, but then flares at the time of their cancer diagnosis, but also to address issues of dual diagnoses, which has become a crisis in the United States. So I think that the most important thing to take home from my relationship with ASCO is they heard you last year, they hear you now, and there will be work going forward on that.
Okay, we're just moving it along. Okay. Good afternoon. Sorry to interrupt your lunch if you're still eating. My name is Michael Sharp, and I'm here as the president-elect of an organization called the Academy of Consultation-Liaison Psychiatry. If you've no idea what that means, don't worry, I'll say it. So there, amongst psychiatrists, there is a proportion of them who specialize in the care of people with medical illnesses. And that, because it involves liaison or linking and consulting, has got this rather silly name, Consultation Liaison Psychiatry. But they're important for this meeting today because that's an organization, the ACLP, which has 2,000 psychiatrists in it. And the mission statement of the organization, I've actually written it down in case I didn't know it, but basically it includes promoting excellence in care for patients with coexisting psychiatric and general medical conditions. That is the core mission of the organization. And Kelly, I think you're a member, are you, Kelly, at least? Yeah. I know she goes to the meetings. So they are, that is potentially an important group for what we're talking about today. I just want to say a little bit about the terminology. And we have the same issue in the UK as you do here. The good news is that mental illness is probably in general more talked about and better accepted. The bad news is, as one of my colleagues said, he rather suspects that we've changed mental illness to make it more acceptable to the public than change the public to be more accepting of mental illness. And we have this term mental health used, or mental health issues. And I don't know what you think. I think that's a little bit of a disservice because it isn't all the same thing. Mild distress is not the same as bipolar and schizophrenia. And I think we should be talking about specific illnesses and dignifying those illnesses as we do with other medical conditions, and not lumping it all together as a lump of mental health issues. But that's just a view, because I think what I think ACLP want to say is the care you get for your mental illness should be at the same standard as the care you get for your cancer. You shouldn't accept inferior care. So the second thing I want to say is that we've got a lot of disciplines here and a lot of organizations here, and everybody wants to help, which is great, but I also think we need to think about how we work together. And we were at the meeting yesterday, and I borrowed an analogy that Atul Gawande uses. He's a surgeon that works in Boston. And he says, when we're training doctors, we train them to be individual practitioners who go out and do great stuff. He describes this like training cowboys. You go out into the Wild West and you do great stuff. He said, that's not enough anymore, because none of us can do this on our own. So oncology, we heard this morning, can't do it on its own. Palliative medicine can't do it on their own. Social work can't do it on their own. And guess what? Consultation-Liaison Psychiatry can't do it on its own. And so we have to find a way to do this together. And the analogy that Gawande uses is the pit crew. And the pit crew are those, I say guys, they usually are guys, who service the racing cars when they come into the pits. And do you know how long it takes them to change the wheels on a racing car? Any offers? At the top of their game, 2 seconds. 2 seconds. And the way they do that is they all have a specific job. You know, one guy does the front left wheel, the other guy does the rear right wheel. And they've trained to work together. So they bring what they bring. They don't get hung up on what their organization is or what their discipline or what their role is. They bring a skill and they work as a team. And that, I would suggest, is how we need to be thinking about going forward. And certainly I'd like to say, on behalf of the Academy of CL Psychiatry, that's what we want to do. Thank you.
Great, thank you, Michael. I think I actually live in Indianapolis, with the heart of the Indianapolis 500, where the pit crew analogy is often, I think, so important that we translate that into our healthcare, and particularly in cancer care. And I would venture to guess many of us as professionals feel that frenzy and excitement and fast pace. We have to deliver care every day, and it's only getting bigger and faster and more challenging. With all of the great advances happening in oncology at a faster rate, I've been an oncology social worker for 35 years. I have to say, I've never seen the level of progress that we're seeing now over the last just very few years. And even the physicians can't keep up. The other professionals, we're having trouble keeping up on top of the fast-moving changes. Our patients and families are struggling. Our institutions are struggling with adapting care. So there are many, many issues that are facing us today. I'm pleased to be here today as president of the American Psychosocial Oncology Society, affectionately known as APOS. We've been around close to 33 years, founded by our leader and really the grandmother of psycho-oncology, Dr. Jimmy Holland. And our real mission is to advance the science and the practice of psychosocial oncology, and to create an intersection of where those meet together, right? Where our clinical practices, what we do day in and day out with patients and families, those interventions, those skills, those talents are evidence-based from the research, and that we're constantly able to bring what we're learning in the research about what helps people the most. We're actually training others to really integrate that and to better understand how to integrate that information into practice. We are interdisciplinary, so we have over 650 members, everything from psychiatry to psychology, social work, nursing. We've added some art and music therapists in the last year. We have some chaplains. We are really striving and want to continue to expand, attracting members of the entire care team in oncology. We have a variety of ways you can be involved. We offer online webinars and courses that you can take for CME credit. We have an annual conference. We just had our conference in Atlanta a few weeks ago, where the latest research is presented, the latest new information about how to improve the care and the clinical practice every day is presented. And we have a great dialogue and community. It always kind of warms my heart when I see a group of researchers and practitioners clustered around a cocktail table. And while they may be having a good time talking about their lives, they're also exchanging really valuable information and insights about the work that we do every day. We also have a professional journal that is growing, and it's Impact Score, the Journal of Psycho-Oncology. And we're really proud of the contributions. And in response to Dr. Ryan's opening remarks about proving it, we have hundreds, if not more, across through our international psycho-oncology colleagues who are doing research, who are demonstrating and bringing data forward that the work that we do not only improves quality of life, it leads to better health outcomes, and the most important thing that we are charged with defining now is how do we reduce the cost of care, that our services actually have an impact on the bottom line, to Dr. Ryan's point, prove it, right? So that we can demonstrate the importance of not just adding more staff, but giving the efficiencies and the abilities for those staff to work to the highest of their license and to deliver high quality care. Our vision at APOS is that we are a nation where all people have access to quality psychosocial care in order to improve their health outcomes. And we use that data every day to continue to advocate to give our members and their institutions valuable information to build a case for more staffing, for better access, for changing clinical care and really reinventing the way we deliver cancer care in this country so that psychosocial care isn't an afterthought, but it's at the hub and the very core of what we do and how we deliver patient or person-centered care. Many hospitals, many providers, many large institutions and small say they're patient-centered because they put like something beautiful in the lobby, or maybe they decided to give free parking. But yet the structure has not really changed. We're still putting patients through a very rigorous and often unfriendly, no matter how sweet and nice we are, the culture of the system hasn't changed. So at APOS, we're really committed to bringing that evidence and the practice together to create new models of care in psychosocial oncology.
Thank you. Let's see, can you guys hear me? Is it on? Okay. Hello again. I just would also like to say that Vicki here is a past president of AOSW as well. So she's one of a very few who've been a president of both organizations. Both are amazing organizations, by the way. Again, I'm honored to be up here this time really to officially represent the Association of Oncology Social Work and to share with you some information about why AOSW believes that this endeavor, this collaborative, is such an important one. For those who don't know, AOSW is a nonprofit international organization of over 1,400 members dedicated to the enhancement of psychosocial services to people with cancer, their families, and caregivers. And our mission, very similar, we have similar missions up here, is to advance excellence in psychosocial care of persons with cancer, their families, and caregivers through networking, education, advocacy, research, and resource development. And we do have very similar approaches to how we do those things with conferences and online education and regional meetings and things like that that are targeted to members, and we just recently had Kelly and Amy do a talk on their work, a webinar for our membership, and we invite and work with other organizations. APOS and AOSW have done joint conferences together. So we're very, very collaborative, and one of our strategic goals is connectivity, which is why we're here. We want to connect people, organizations, and information to promote psychosocial oncology. And we do envision a global society in which oncology care meets the physical, emotional, social, and spiritual needs of all those affected by cancer. And our scope and standards of practice are filled with statements that support the mission of this symposium, the Collaborative Care Community Engagement Program at MGH. And I'm just going to share a few with you. Things like advocating with or on behalf of survivors, families, and caregivers to address their needs and for policies and programs that will benefit them. Proactive provision of services to at-risk populations I hit on earlier this morning. Collaboration with patients and family members for professional disciplines in the delivery of care. And advocacy for the protection of patients' dignity, confidentiality, rights, and access to care. We aim to ensure that the agencies and institutions are responsive to the needs of both individuals, cancer survivors, families, and caregivers, as well as groups, and to contribute to interdisciplinary efforts to provide quality medical psychosocial care to oncology survivors. We want to ensure that community programs and resources, because this is the future, right? Again, we hit on it earlier this morning, and it's a theme about, my words are, crossing institutional boundaries, but the team, what does the team actually look like? And that's where we look outside of our own settings to who else can help take care of our patients and families. So to ensure that community programs and resources address and are responsive to the needs of cancer survivors, families, and caregivers. More collaboration, both with community agencies to remove barriers and collaboration in the development of special programs and resources to address community-based needs. So it's these standards that guide AOSW as we look forward with ways to collaborate with our esteemed colleagues here and with the collaborative and with you in preventing both premature cancer mortality and to improve the quality of life of individuals affected by mental illness and cancer. Of course, if you'd like to learn more about AOSW and APOS, we have tables out there. We're here supporting the conference.
Thank you. Good afternoon. I am a recent addition to this panel, so please bear with me. I work for Nami, Massachusetts, which is the state organization of a national organization called Nami, National Alliance on Mental Illness. We have 17 affiliates around the Commonwealth. These are grassroots organizations headed by volunteers who provide education and advocacy at the local level and endeavor to reach out to families and individuals who, I'm sorry, Dr. Michael, but individuals who are living with a mental health condition and working towards their recovery and well-being. We work hard to reduce the stigma involved with mental illness and to improve the quality of life. We are the largest grassroots organization on mental illness in the country, so we would welcome all of you to consider joining us and joining with us as we endeavor to improve these folks' lives. I'm going to tell you a little bit about my background and interest in this endeavor. I first became interested in the work of the Engage Collaborative in the hope that I might find some useful information regarding the effect caregiving for a cancer patient might have on the caregiver's mental health. When I was 16, my widowed mother was diagnosed with lung cancer. She had surgery, but within a year, the cancer had metastasized to her brain. Back then, a craniotomy was performed. She had cobalt treatments and was left with aphasia and paralysis on one side. My older sister was away at college, and my younger brother was 8 years old. I became caregiver to my mother and brother in my senior year in high school. In April of that year, my mother was admitted to the hospital and then to a nursing home where she died at the end of June. In September, I boarded a plane and came to Boston alone to begin my college career. After a couple of changes in major and a few bumps in the road, I graduated in 4 years with absolutely no idea of what I was going to do next. Within 2 years, I was hit hard by depression. Friends and talk therapy helped me along the way until one day I realized I needed to learn everything and anything I could about cancer so I could begin to plan and live my life without fear. I enrolled in graduate school for counseling, became a volunteer at the Cancer Information Service telephone line, which led to a job with the American Cancer Society and other subsequent human service jobs. In my 40s, after years of resistance, I began taking antidepressants. At age 50, I was diagnosed with a DCIS stage 0 breast cancer. I had a lumpectomy and radiation therapy and 5 years of tamoxifen. At age 64, I was diagnosed with an HPV-related cancer. I had surgery and then 30 radiation treatments bracketed by 2 72-hour chemo infusions. By the way, my radiation schedule included the entire month of February 2015 when Boston had 8 feet of snow. During this time, I found every which way to get from Beth Israel Hospital back to my house via all kinds of different routes. And at this time, I continued to work full-time and am now considered cured. I began working part-time at Nami, Mass. In February of 2017. Suddenly, I was confronted with the idea of living with a mental health condition. Who, me? It was cancer, not mental health, which defined me and my family all my life. Wow. I realized I had more fear and concern about being upfront about living with a mental health condition than I had about having cancer. I was living with and just demonstrating stigma and discrimination against myself. We talked a little bit about Nami. Nami was founded by family members who decided to reach out and share their experiences and concerns about their loved ones. Nami sponsors free programs like family support, peer-to-peer, family-to-family, and programs for educators and public safety personnel. These programs are all free, and they are all delivered by trained facilitators who are volunteers. Nami is well aware of the disparities in health outcomes for persons with lived experience, and through its many programs, attempts to address the discrimination and advocate for change. I believe, and I know, that the Engage Collaborative will provide solid evidence that when people living with mental health conditions have access to cancer care with psychiatric support, outcomes will improve, and we will close the 25 to 30-year gap in life expectancy for those with diagnoses of serious mental illness and other serious physical illness. Coming from a family with a history of many different cancers, trauma, and addictions, I never expected to live to the age I find myself now, with 3 little granddaughters. I hope our efforts will provide the same opportunities for those we serve. Thank you.
Ruth, thank you so much for sharing your personal story and in many ways reminding us that when we talk about stigma, how this goes both ways with respect to how do I interpret my experience around mental illness, and then also what does that mean to have that and cancer. And the barriers around stigma are profound, and it underscores how important it is for we as clinicians in hospital systems and community clinics to create an environment of compassion and care and safety, coming back to our credo, to ensure that no one has to feel that when they walk through the door. I want to open this up for discussion more broadly, but I want to link, I have a question for the panel that I'd first like to share, linking some of our morning conversations to this. We heard from Dr. Jackson and Dr. Shin and others about the involvement and integration of palliative care early in the course of disease for patients with advanced cancer. And my colleagues and I have been testing that model for over a decade and have a real large evidence base about its positive effects on patient quality of life and caregiver quality of life and mood and depression symptoms and their outcomes even at the end of life. And one thing that we've been humbled by, despite the evidence and the effort nationally to implement and disseminate that model, we simply don't have the resources. So hospital systems don't have enough palliative care clinicians and psychiatrists and psychologists and social workers and chaplains to meet with every patient with advanced cancer at least monthly from the time of diagnosis. And so the question becomes, well, how do we think about delivering that care at a population level so that more people have access, yet still benefit from those good positive outcomes, like having better quality of life and feeling that they are truly heard, seen, and cared for? And so I want to link that back to here because I think we're in a similar nexus. We're developing a robust evidence base about the integration of, proactive psychiatry consultation and collaborative care, but are we sort of setting ourselves up again for a high-level model that's very robust, that we know works, that we are going to struggle with implementing at a national level? And so with that backdrop, do you have any ideas about what next steps ought to be? Yeah, I'll just leave it there.
So in medical oncology, increasingly the thing that drives most of what we do is payment. The payment models are evolving to include episodes of care. And I think that the idea that a model of care that includes all facets, and I can't work in the pit crew because I can't think that fast, but I can play in a symphony. So, but I think that
play music while the crew works.
But I think while each person in the team is doing their job in concert, that if we could demonstrate reduced cost to the system, that is really the way to move this forward in a way that we can pay for it. So just as a medical oncologist, I think that we have to be really cognizant of the fact that a lot of what we pay for as the psychosocial care of patients is not directly reimbursed. And it is funded on the back of drug pricing, quite frankly. And we as a society are trying to move away from that. So much of what we're talking about today to provide care for any individual is unreimbursable. And that's the stigma we all live with. And so to fix that model and to show that this model is cost effective is going to be key to not only its sustainability, but also its ability to be rolled out in areas where the resources may not be as robust.
So one of the things when we think about really good mental health care is it's in a way it's an antidote to over-technical medicine, where sometimes it seems that there's so much of a technical task for the physicians that other bits of the patient get lost. But paradoxically, I think the answer to better mental health care for cancer patients throughout the country and elsewhere may be in technology. So in the academy, one of our most famous members and past presidents, who somewhat ironically died of lymphoma several years ago, was a man called Wayne Caton. And he was a New Yorker who worked in Seattle. And he was passionate about improving the mental health care for all people in primary care, because what he saw is if we just take depression, that was a focus, it wasn't well treated in primary care. So he thought, well, how are we going to fix this? So he went and spent time educating primary care physicians. And he wasn't just an advocate, he was a scientist. And so he did careful trials to see whether that made any difference. It didn't. He said, okay, maybe the problem is that they're not recognizing who it is who's got depression. So as well as training the primary care physicians, he put in place systems to identify everyone who was depressed. And then he did another trial. Did it make a difference? Well, there was more treatment given for depression, but the outcomes were no better. But being the kind of guy he was, he didn't give up. So he said, okay, maybe actually good management of depression does need an expert. But how could one guy called Wayne Caton serve all the primary care in Seattle, let alone the United States? And so he developed a model called collaborative care, sometimes also called integrated care or team care. And this was a way for their psychiatrists to be advising on the care of patients who still remained under the primary care physician, who got additional attention from what we call a care manager, who might have been a social worker or a nurse. And they worked as a team in a system. And then he got real good effects. And this collaborative care model has been shown to be of value in a range of psychiatric conditions, not just depression now, and latterly in more what we might call more severe mental illnesses. And it's also been shown to be effective in depression in cancer care. That work's been taken further now by some other colleagues using telemedicine. So I come back to technology. So I suspect what we need to do is to extend our, not to assume that if you live somewhere away from MGH, which I always think of now of man's greatest hospital after the, anyhow, if you live a long way away from MGH, it doesn't mean you can't benefit from MGH standards of care. You have to put up with someone unskilled or untrained. It means that we have to use technology to help not only train people in those places, but actually to provide expert consultations and extend our teams outwards. So that's, and this is, I'd like to just finish by saying that the work that Kelly's doing builds on that long tradition of collaborative care, really focusing on this space of more severe mental illness in the cancer setting, using the learning from collaborative care. And I think that's really important. And I know she's also going to do trials to just see, you know, how helpful it is, because we can't assume these things are. And I think that's a really important next step. So clinical trials, telemedicine, working as a team, keeping the same level of expertise for everybody, and not assuming people away from MGH need to get bad care.
Yeah, I'm so glad you pointed that out, because I think, you know, clearly our current system of delivering psychosocial care, certainly within oncology, is really, it needs to be dramatically and rapidly transformed if we're going to continue to provide best value. The current system we have is not sustainable. As you said, it's not reimbursed. So the idea of models like the collaborative care model that is highly successful in Seattle, the work that Kelly's doing here that's really much more engaging, a community model, this is really where we have to start to look. And I think we have to, in some ways it's kind of going back to our earlier roots of where we did go in the home. We, you know, many of you may be familiar with a new payment model that's being tested called the Oncology Medical Home. Well, there's also now a model being looked at called Oncology at Home, where they're actually looking at delivering treatment at home for those patients who would be best suitable for that. So we're really starting to kind of come full circle in our healthcare system, because we know that this model is severely limited, not just in the delivery of psychosocial care, but in medical care as well. You know, you've heard of the kind of silver tsunami, right? We have now almost 17 million people in the U.S. with a history of cancer. That's 5% of our population is touched by cancer. Predicted in the next 10 years, that number is going to go to 22 million people affected by cancer. So I'm really worried about those, let me think my math, 5 million people between today and 10 years from now that are going to be affected by cancer? How are our healthcare systems going to meet their physical needs, let alone their emotional, social, practical, logistical, spiritual needs that we need to think about? So I agree, it's about reinventing how we think, how we deliver care. Our traditional models of here's the nursing department, here's the social work department, here's the chaplain department. How are we going to create this more interdisciplinary, dynamic approach that is going to get to where the patients are? And again, while there are incredible comprehensive cancer centers in this country, a vast amount of care, like 70%, I believe, is being delivered in a community oncology model. Not anymore. What is it now?
It's a little bit less, it's actually a little bit less than 50-50.
Oh, okay. Yeah. Well, that's good to know. Good to know. But I think what the struggle is for those community care providers, they don't have this wonderful kind of interdisciplinary access to resources that the bigger institutions have. So we are really challenged to work collaboratively across the ASCOs and the different organizations, including mental health, to come together and figure out some more innovative, cost-effective solutions.
I completely agree, and I just want to follow up as well on what you said about collaborative care and the use of technology and telehealth. There are a number of funding mechanisms out there that actually do promote collaborative approaches to care, one of which we've taken advantage of through my university, not AOSW, but the HRSA funding mechanisms for workforce development, and that looks at rural community-based care that integrates behavioral health with primary care and includes telehealth. We have an ECHO model that we're testing to really target rural communities who don't have access to all the resources and things that the larger cities have. So they're out there. And the other thing that I would say is go upriver. Any of us who have responsibility for learners, students or other learners, instill in them early. I'm a big promoter of interprofessional education. All of the grants that we're doing are interprofessional education grants. Instill in these people early, teach them about collaborative practice while they're still in school, get them out of their learning silos, and help them solve patient challenges while they're still in school so that they just think it's normal. They go out, they graduate, and they're like, got physicians asking for their social workers and their psychologists, and everyone's asking for everyone. Who's my team? And then they start working and doing this future of this care that we're all looking for. And I do see that it's making a difference. We are now currently trying to test patient outcomes of the impact of the interprofessional education efforts that we're doing in teaching collaborative care. And that's a hard thing to do, but we're trying it. The other thing I would also say is, as a past president now of a national organization, it really is important. Like, none of us probably, when we were going to school for our healthcare focus, really realized how much advocacy and policy work is ultimately super important. Yeah, we all thought it was probably boring in school, but we really need to vote for the people who will fund, who will put in the budgets at the city level, the state level, and at the federal level, the things that we want to do. All these things that we're talking about, we need to get funding, and that comes from our vote. We need to show up at the booth and vote.
Absolutely. I couldn't agree more. Nami, in the past 18 months or so, was advisory and collaborated with the Department of Mental Health and Medicaid in Massachusetts to begin to cover case management in services to people with chronic mental illness. And I think that's very important, that this has taken down a wall between medical provision and at least scratching the surface of social work in order to provide patients with good case management services and break down a lot of walls in care for them. It's not funded well yet, but I consider it at least a start. And I think that's, the mental health system is becoming medicalized in a way, because that's what Medicaid wants to do, is see some, credentialed people, medical supervision, but at least it's a start.
Thank you all so much. I mean, it's inspirational, it's energizing to hear your creative ideas, especially representing these national organizations, to hear your creative ideas about where the future lies and to hear about that vision. So thank you. We have about 10 minutes or so. I would like to open it up to a conversation with you all. Do any of you have any questions that you'd like to ask our panel? Yeah, over there.
Hi. As a psychologist who works as a training director, training future psychologists in an integrated care model, I'd like to comment on this, thanking you guys for making this sort of in the spotlight, and the fact that you're commenting on the economic piece and that side of it. What we're finding is that oncology is funded here, and my future doctoral people working with your patients are funded here and are making this much money, which makes them want to do other things instead of this. So what I would wonder is there any sort of movement in a high-profile type of medical setting that promotes oncology to advocate for, or even on a political level, require that the disparity, the payment gap between mental health providers working with oncologists be made much smaller?
Thank you so much for that incredibly important question. I think this really gets back to my colleague's comment about voting. Currently, we are constrained by how Medicare pays for cancer care. And Medicare essentially pays for visits and for technical charges. The technical charges are essentially administration of chemotherapy and radiation. And that's it. And what we're talking about in this conference is the entire collaborative care model, of which the vast majority of it has no direct reimbursement. So how do you pay all of those other folks that are required for this pit crew or the symphony? And basically, it really is what's left over after you've administered drugs or administered radiation. And that's not right. We've known that's not right, and there's a pejorative sense in the world that oncologists are getting rich by giving chemotherapy. That is mandated by the government. We can't say, gee, we'd really like to get paid for thinking, because that's what we do say. But the government tells us, CMS, how we get paid. And that's what drives this entire bus. So if you want the bus to go in a different direction, you need to vote in a different direction.
Or run.
Or run.
For office, that is.
Or just run away.
Yeah.
So here's a message. It's a kind of shocking message that we have to get out there. I worked for a long time in Cancer Research Center and encountered lots of colleagues carrying small bowls of zebrafish, which are pretty little fish. And they study zebrafish because, as you know, their makeup is such they're a useful model for cancer. But the reality is, in the world, cancer doesn't exist. You can't find a cure for cancer. You can only find care for people with cancer. So the whole idea that we're providing care for cancer is actually, when you think about it, a bit odd. We're providing care for people with cancer. And so the system needs to be organized to care for people, not just to care for zebrafish.
Can I make one more comment?
I do think, though, that that it's incumbent upon, and getting back to your really, really probably the most important question of the day about how people are paid, because none of us can do this sustainably as a volunteer, it is really incumbent upon the national organization and the one I represent here today to actually get these white papers out so that advocacy can occur. Because without, and you know, ASCO's, their credo or their mission is conquering cancer through education, research, and advocacy. And without being able to have an advocacy platform, we can't go forward. So I think that's a really important thing for all of us to take back to our organizations.
Other questions?
I was just struck, I wonder if I'm the only person who happens to be a member of 4 organizations up there. Well, I just need to speak to the fact that we don't often get the chance to come together. So I just wanted to express my gratitude. But I think that's part of how the change and creative probably often happens when you're walking amongst ASCO and ACLP and APOS and Nami. And so like while they're here, I just wanted to say like this is an opportunity. If you hadn't had the opportunity to learn about APOS or Nami and you're curious, that's just a good day to ask those questions because there are resources that are available and help.
I think that picks up another question I had is, you know, we are, all of these organizations also, to some extent, are in silos based on discipline. I mean, APOS is a little bit different in that it's a multidisciplinary organization, and ASCO to some extent. But how do these organizations actually join forces to have a broader chorus to make change? And do you see efforts to make that happen across your organizations?
Yes.
Yes,
Yes.
yes, yes,
All the
and
time. yes,
right?
Yes. I mean, this is a classic example.
Yeah.
If not for the organizers of this conference, we wouldn't all be sitting here. But National Coalition for Cancer Survivorship brings people together. You know, there's the ONS, the Oncology Nurse Society, brings people together. I mean, so it does.
It does, and it's so important. You know, one case example then, so if you look at the advent of distress screening now as a standard of care, thanks to the American College of Surgeons Commission on Cancer. So no matter how you feel about distress screening and some of the challenges with it, that was almost a 30-year effort of collecting data, proving the concept, demonstrating and validating tools, and finding resources, moving it into technology so we're not passing around pieces of paper to patients to have them evaluate distress. And what happened is we began to move forward and get it moving into now a standard of care. A multitude of organizations came together, ONS, AOSW, many of the survivor groups and others, to put out a white paper and a position paper that said, this is the standard of care and this is how it should be delivered. And I have to say that is probably the advent of distress screening, one of the most important shifts in psycho-oncology that's happened in the last few years. And that only ultimately came to fruition because of the collaborative effort of many different professional societies and a kind of joint commitment that, again, it wasn't about each of our silos, it was about that total care. So it works.
Well, that does bring us to the end of our panel today. Thank you so much, honestly, all of you, for joining us and talking about your organizations and the work you do and thinking about how we can link together collaboratively and become a village to make change. So thank you. So